I will speak in English, but so I've done this talk many times, and so I feel like this guy going up and down this perpetual ladder, and I've done different versions of this talk, and I'm hoping that it will make an impact by one day. So this is actually a continuous staircase by Lionel Penrose, who was a professor at University College London, and I will get back to him. So I have no disclosures except federal grant funding. I don't have any commercial support. So I'm going to review the topography of comorbidity of mental disorders in individuals with intellectual disabilities, and I'm going to talk about the social adversities and discuss strategies for service gaps and principles, actually. I'm not going to go specifics into interventions. So this is Lionel Penrose. He was a Quaker who during the Second World War did not fight for England, but went to Canada and lived in Canada, worked in a hospital, and then subsequently did a lot of research on science of intellectual disabilities and pioneering the genetic study of learning disabilities. And he became a professor, the Galton Chair, which was once held by the cousin of Charles Darwin, Sir Francis Galton, who was the person who essentially first used the term eugenics. And eugenics, of course, was very important in the history of intellectual disabilities. I'm not going to talk about that. That's another talk. So this is a dedication because I get a lot of support from the Fogarty Center. This is Teddy Kennedy, who died a few years ago. And the one with the person with the bow tie is John Fogarty, who died at age 58 from a heart attack in Congress after being elected 14 times. He essentially changed the history of American funding for federal funding, establishment of medical schools. He's one of the most important people in American health history. They called him Mr. Public Health. If he was alive, we would have universal health care in the United States today. So here he is with John Kennedy and signing the appropriation for support for the labor and health, education and welfare, which essentially expanded funding for National Institutes of Health in the United States in 1961. So we published a paper, and I was actually the last author on this, but Shekhar Saxena, the head of the World Health Organization, wanted to be on that, so he became the last author. But this was a new framework for a definition of the intellectual disability, what used to be called mental retardation. And after a number of series of meetings of an expert group that essentially came with recommendations for changing intellectual disability definitions for the World Health Organization. This is the group, and as you can see, it's a very international group. It includes people from Mexico, Lebanon, Hong Kong, China, Scotland, Spain, South Africa, India, United States, and myself here. So the global burden of disease, everybody talks about this. This is a highly biased framework for children. Also, it's a biased framework for intellectual disabilities individuals. But despite that, it gets ranked in the top 20 of the GBD. I just want to also say that the lifetime cost of the, just to give you an idea of intellectual disability with autism is 2.5 million. That was in 2015 in the US, and it's very concordant with also United Kingdom and Germany. So this was a prevalence meta-analysis that on the 52 studies that were published over a 3-decade period that showed a prevalence of 1%, which is vastly underestimated in the meta-analytic studies. And the prevalence varied by income group of the country in origin, and of course age group of the study population and the study design, and there were higher prevalence rates when dimensional measures were used as opposed to categorical measures. and higher in studies in children and adolescents versus adults. I will get back to that in terms of the measures. So, evaluating the evidence, we find that the prevalence of mental disorders in intellectual disability populations actually vary between 10 to 60%. So variation is due to methodological issues, sampling size, and so on. And the definition of the intellectual disability has been on IQ alone, which is the cognitive functioning alone, which is distinct to what we actually proposed in the World Health Organization, and I'll get back to that definition. IQ measure also use the definition of a boundary of intellectual disability, which I think I'll also get back to, which is very important, between these 70 to 85, which is just the boundary above mild mental retardation. And the institutional and clinical samples led to inflated estimates of comorbid mental disorders, so therefore they're not representative because there's a select group. And general population samples lead to underestimates because they don't ascertain individuals with intellectual disability. Same problem arises with research on psychosis and schizophrenia. So case registers under-identify persons with mental disorders and intellectual disability. So the expert consensus recommendations were that experience is the same mental disorders as the general populations. And I actually wrote a paper talking about, one of my favorite papers is this mourning or grief bereavement in individuals with intellectual disabilities, that they actually experience bereavement responses. And it's actually much more consistent with traumatic grief, which is the more complex and long-standing grief, as opposed to shorter-term neurotypical grief, which is now lost in psychiatry because it's considered unless you're depressed. So mental disorders in persons with intellectual disabilities occur at a higher rate. Inadequacy of the mental health services is correlated with that, and much of the criteria that needs to be adapted require better methodology for assessing mental disorders in this population. So let's get to the dimensional measures of challenging behaviors. Now, many studies, that when they report prevalence, they talk about challenging behaviors because they don't really know how to measure, or they can't have the time to ascertain diagnostic categories in this population. It takes more time and it's difficult. So they used different dimensional measures. One of these that I'm actually going to talk about, some of the research findings, is the Developmental Behavioral Checklist here on the top, which was developed by Einfeld and Tong, and it's basically similar to the Child Behavior Checklist, those of you who might know, which is developed by Tom Achenbach in Vermont and has been extensively used by Tom and also Frank Verhulst as well as in Turkey by Neşe Erol in ascertaining many profiles of child and adolescent disorders. So the strength and difficulties questionnaire, you're aware of that. There's the aberrant behavior checklist, which is actually used in medication drug studies and looks at some of the aberrant behaviors. It's pretty intensive and it's very sort of focused on really significant disruptive pathological self-injurious behaviors. And the Niesinger Child Behavior Rating Form from Ohio, which is a very important center, again where Michael Amann is, and then overt aggression scales, and so on and so forth. I can go on with many other dimensional scales. So the discrete measures of mental disorders in intellectual disability is also extensive, and I'm going to summarize them. And the fact that actually there's a DSM-5 and the ICD and an ICF doesn't necessarily actually mean that they're very specific to intellectual disabilities. They're not. And so in order to resolve that problem, a group which is called the National Association of the Duly Diagnosed, NADD, led by Dr. Fletcher over many years, adapted the DSM-5 structure of diagnostic categories for intellectual disabilities. And I was actually very concerned about that because I didn't want to segregate the intellectual disability definitions. Like, we don't want to segregate, but like we can have a definition, diagnostic classification book for children, for example. We can have one for adolescents. We can have one. So we should really not be separating, segregating this, because people with intellectual disability have been segregated all their lives. So I didn't really feel that way. But on the other hand, it's actually a useful document for teaching purposes. But it hasn't been validated very carefully. The DCLD, which is the Diagnostic Criteria of Learning Disability, has been extensively used in Scotland by Dr. Sally Ann Cooper, who's done a lot of work in the field of intellectual disability in adults. And of course the ICF, which is, because intellectual disability covers both the International Classification of Functioning and International Classification of Disease. And these two don't necessarily overlap. There's also problems in the way that they coordinated services and definitions, because there are different committees, politics. All right, so this is the DMID I told you about. This is the Fletcher, and Dr. Cooper was involved in this as well. So I'm going to just very briefly go over that. So what did they do? What they did is they looked at symptom equivalence, they looked at omission of symptoms, symptom count, duration of symptoms, age requirements, and they added explanatory notes, which also exist in DSM, and then also said, well, these criteria might not apply because they'll not be valid. So this was the approach that they used to modifying what they thought should be adaptation for diagnosing these disorders in the population of intellectual disabilities. They don't make a distinction between different subtypes of developmental disabilities, for example, intellectual disabilities like mild, moderate, and severe, and profound, or verbal and nonverbal. They don't make those kind of distinctions. Okay? So, so these were applying the DSM-5 criteria to the DMID-2, the expert consensus model, and I give you an example. For example, the autism spectrum disorder and OCD required no adaptation, and attention deficit, multiple adaptations of the criteria, and then conduct disorder, no adaptation, anxiety disorder, no adaptation, PTSD, adaptation for mild and severe and profound IDD because of the expressive nature of some of these things. And then the depressive disorder, some adaptations from mild to severe, profound. So there is an element of qualitative approach to this. So I'm not going to be very critical because I think it was a good effort to make these changes. And hopefully in DSM-6 or DSM-5 version 0.1 or 2, there will be some modifications. So for each comorbid mental disorder, they also specify risk and protective factors. This is risk factors, protective factors, as you all know, and the characteristics in the individual, family, and the community that decrease the impact of negative factors on outcomes. And resiliency is essentially doing outcomes in the face of adversity that might be surprisingly positive in some individuals, despite the fact that, similar to other individuals, they've been exposed to adversity, but yet they do much better. This is a term that was developed in Minnesota and the Department of Psychology and is extensively used. So this is the new definition. Okay, so this is the new definition in the DSM-5. So what was so pleasing to us was that there was this meeting in Sicily. It was the first time I went to Sicily. And there was a town called Nicosia, which is, I was born in Nicosia, Cyprus, but I think there was a town in Nicosia, so I looked at, there was a direction to Nicosia, and I said, wow, this is an interesting place, because the Italians were in Cyprus as well. So it was a wonderful meeting, and Jim Harris from Johns Hopkins, who led the DSM-5 task force on intellectual disabilities in the US and the DSM-5, was there with me and from the United States and some others from the committee. And basically, he was so impressed by the recommendations and discussions, so he incorporated to the DSM-5 definition. This was an amazing success, because this was an ICD-11 meeting. And it essentially transformed DSM-5. So I just give you some background information. And he wasn't drunk at the time, because he doesn't drink that much alcohol. So what is this definition? Well, this is actually, for the first time, it does not include IQ ranges. So there are no IQ specifications except this ordinal nature of mild, moderate, and they left it because they thought we can't really throw that away because it would be very confusing for people. The emphasis measures of executive functioning, of course, was very important, and there was a discussion about how do you define these terms, and so the executive functioning tasks, neuropsychological tasks were very important, but then you had the ICD-11 relevant to the whole region of the world with poor resources. So how are they going to do neuropsychological testing in, for example, India? Satish Krimaji, for example, at the National Mental Health Center in India was there, and so he had to be convinced that we can make certain recommendations that will be inclusive of poor resource regions as well. So deficits of intellectual functions and the deficits in adaptive functions that result in the failure to meet developmental socio-cultural standards, okay? And then onset of intellectual adaptive functions during the developmental period. So the developmental period is left again because there is no age specification of the developmental period. So before it was age 18, there was an age cutoff of 18. For example, the other issue is that if you had a traumatic brain injury at age 3 and you have intellectual disability by virtue of having cognitive and adaptive functioning, you will have intellectual disability, but you also have traumatic brain injury. So there are specifiers in this definition. So it's not all congenital neurodevelopmental delays and that occur, although that's the majority of the framework. So the framework works, and the important aspect of it was the adaptational functioning. So this is a very important, actually it's one of the few disorders where actual functioning is part of the criteria itself, because many disorders in psychiatry don't have functioning in it. Okay? Tell me if you think they do. So the adaptive functioning, how the individual copes with the demands and how capable they are of living independently. The key word being living independently, not being dependent on others, making decisions, not needing a guardian when they are age 18. For example, needing guidance on managing money, not being able to manage a bank account, not being able to maybe sometimes dress and buy their clothing, not being able to cook and function on their own. They need supervision, depending on the degree of the intellectual disability on these individuals. So these were then defined as conceptual skills. These are actually, I have to give credit to Jim for that. These are conceptual skills, which includes these ideas of money concepts, reading and writing, and then social skills. And these are things like self-esteem, naivete, obeying laws, and so on, which is broader than what you have in autism. And then the practical skills, personal activities of daily living, such as eating, dressing, and occupational, maintaining a safe environment, being able to function adaptively in some kind of a vocational or employment type of a setting. So this is in the US, since we passed the American sort of health insurance for everyone, which is called the ACA, and that was passed by the Obama administration, which the Trump administration actually tried to dismantle, not successfully yet. So this is a very important group, which are called the National Core Indicators, and this is something that every country should have. And I'm very proud that in the United States, despite all our problems, we're very, very advanced in this field of intellectual disabilities, actually. So these national core indicators are essentially tracking and data on individuals with mental disorders with IDD. So these are individuals with intellectual disabilities. They're tracked in terms of services, in terms of comorbidity and other types of factors, and over time. And this data is collected because they're eligible as adults to receive services, and also as children to receive educational services and supports from the states, as well as, and is mandated by the federal government. And this started with the first picture I showed you because of Fogarty and Kennedy. in the 1960s, actually beginning in late 1950s, that passed these federal guidelines. So it is no way that anyone in any of the school systems will reject these children for services, okay? So the services might not be adequate, but depending on which state and which school region they are, because they are funded by sometimes the tax dollars of the region in which the children live. For example, if I live in if I live in Nishantashi, for example, they will have much more money from tax dollars. I'm using that as an example. In the United States, somewhere called Nishantashi will give a lot of tax money, and so the schools in Nishantashi will be much better. And also the parents will be more educated, they'll be more demanding versus some other place, like I'm not going to mention where in Istanbul, okay? Otherwise I'll get into trouble. But I can read your minds. All right, so 33% of these individuals with IDD receiving services under the national core indicators, 1 in 3 had mental health problems, okay? So that's pretty high. And this rate was selectively stable over time, as you can see. It stayed the same, and the prevalence of mental disorders in individuals with IDD was as high as 50% in some areas. So the range of comorbid disorders 4 times higher in IDD than the general population. So if you have IDD, you have almost like a 3 to 4-fold increase in your relative risk for having intellectual disability. And these include, for example, so if there's only one co-occurring mental disorder, as high as 39%. That's Eric Emerson's work in the UK also. So I'm just giving, so now let me get to this very important study. This is the study done in Australia, in the Victoria and Northwest Territories of Australia, which is really where most of the population live. And this is the epidemiological cohort of these children and adolescents. They're followed, it's a follow-up study, very important, and recruited from health, education and family agencies, and done by really a very distinguished group of researchers. So I visited with him, I know him, he's an extraordinarily good scientist. So they used this measure, the developmental behavioral checklist, which validated, and they developed also what they called and were published in JAMA, the Journal of the American Medical Association, growth curves of DBC dimensional measures. By the way, this is a platypus, okay? So if you go to Australia, you probably have a 2% chance of seeing a platypus, okay? Because they live in the water and they're hidden, so you can't really see them. So, and that's one of the reasons why 2% of psychiatrists know about this study. All right, so this is the developmental behavioral checklist. These are the dimensions: disruptive, self-absorbed, social relating, more autism related. This is withdrawal, self-absorbed, communication disturbance, anxiety. So the ACAT findings. So the girls score less than boys on psychopathology at baseline. Difference was not statistically significant. That's also true in another study that I'll mention to you. At wave 1, 41% of the participants met criteria. At wave 4, 31%. This happens with use of many dimensional measures as well as structural interviews. When you go wave 1, wave 2, wave 3, there's kind of an attenuation. That's been shown in many epidemiological studies. And differences between initial total scores by severity group were not significant, and more severe the IDD, the less rapidly problem behaviors declined. So these were some of the findings by age, gender and severity of IDD effects, and what I will sort of mild IDD scores higher than those with severe for disruptive. So if the more profound IDD, either you were not detecting the symptoms or that they were not exhibiting the symptoms, and that's what and then this is same also self-absorbed, their higher scores for the severe profound, more withdrawn, less verbal, and because of that they also have less opportunity to talk, because if somebody is not verbal, okay, if somebody has no verbal skills, you don't go and talk to them. Okay, it's you go and visit someone, a family member who has a child who has intellectual disability or autism, and you will find after a while they'll be all schmoozing and drinking tea and talking, and the kid with the autism or this intellectual disability will be left alone, unless the mother knows that somebody needs to be with the kid and talk to the kid, because it's very important to interact with the kid continuously. Otherwise, it's like if you don't run, you're not going to be a good athlete, okay? So you need to exercise. These are important communication issues, and you need to be aware of that. So social relating disturbance was higher for older individuals and higher for those with severe or profound IDD. This is important finding. In contrast, with other scales, increased over time. This is the most important finding, I think, of the ACAT study. The most important finding in a country like Australia. I'll get back to that. So this is actually where I'm talking about. If you look at the slopes, all these things diminished over time except the social relating disturbance. Because these people were, after a certain age, were not receiving services, social relating services, and so they were withdrawing. This is actually, I'm sure it's true, I know that Bora is here, in schizophrenia and other disorders as well, where if you, over time, if you don't interact with these individuals, you let them be, they will be not relating socially, and there will be an impact over time. So the National Comorbidity Surveys, this is Ron Kessler's study that Turkey was part of for a while and didn't do that well, and then I think they're re-entering. But this is a study on adolescents. This was an analysis that was done last year by Platt in Columbia University School of Public Health. So this is actually the first study to assess DSM-5 adaptive prevalence of IDD using both cognitive and adaptive functioning. The first and only study so far that actually uses both. And they're very interesting findings. So what they did, which is very creative, they actually, because they had the Kaufman Brief Intelligence scores, they used the cutoff of 76, which makes sense because there's a standard error beyond 70, because you don't want to just use a 70, that will be too harsh. And then the adaptive behavior score was scaled. They had adaptive behavior measures, and that was scaled and then used as sort of a similar cutoff based on the certain percentile, similar cutoff. And then the age of onset less than 18, and then the composite international diagnostic interview, which they use, which is the WHO interview, and assessed 15 lifetime mental disorders, and then the disability scale assessed disorder severity. So they find a prevalence of 3.2%. Like compared to the Malik's meta-analysis, that's 3 times more. And then 65% of adolescents with IDD met lifetime criteria for mental disorders. That's actually much higher than what I told you in the national core indicators, which is 1 in 3, right? So this is very high. This is a national comorbidity surveys. These are worldwide project. Now, look at the comorbidities here. Very interesting findings. Specific phobia, agoraphobia, and bipolar disorder was emphasized. For the first time, anxiety and mood disorder was more emphasized. And then the adolescents with IDD, with comorbidities, are significantly more likely to exhibit severe impairment compared to adolescents. So severity was higher. But, so again, let's go back and revisit these findings. So, as I said, 65% was higher than the Einfeld result here, the top one. Gender differences in co-occurring mental disorders was absent. Very similar to what Einfeld had found also. Gender differences not very significant. Increased odds of bipolar disorder, greater odds of lifetime phobias. So again, consistent with those findings. An absence of association with intellectual disability, disruptive behavior disorders, contrary to numerous prior studies. That is the monkey's wrench. It's like, that is actually very interesting, because if I ask this group, what would you think one of the most prevalent disorders should be in intellectual disabilities, you would probably tell me it's disruptive behavior disorder and ADHD. But look what happened. So I read this and I couldn't believe it, so I had to reread it and I have to quote this for you. So basically what they said, that many symptoms of behavioral problems are integral to the adaptive. So when they use the adaptive behavior scales and controlled for that adaptive behavioral, they washed out some of the disruptive behavior, because of the disruptive behavior were collinear with the adaptive behavior. So this is how they explain that. So that's a very interesting finding. I actually present that at SAMHSA at Washington, D.C., and there were some people in the audience that said, "Did I hear that?" And I said, yeah, that's what it is. So that's research. Sometimes it produces results that you don't know. So predictors of the persistence of conduct difficulties in children with cognitive delay is a very important person, again, Eric Emerson and Stuart Donenfeld. So when you look at this, you see the more severe cognitive delay is prevalence of normal conduct difficulties much higher, especially increases with the adversity. So there's an intersection between our adversity and the prevalence of conduct problems in individuals with intellectual disability, and that's also correlated with severity. Okay? So here, a variety of adversities that they were exposed, again, 0 to 1, 2 to 3, 4 plus, and as you can see, this is the severe group, and the medium or the less severe group catches up over time, and then the prevalence of borderline or abnormal conduct difficulties. So these are, if you define the conduct difficulties less severely, the less severe group and the more impaired group with intellectual disability catches up over time with the number of adversities exposed. Okay? I hope that's clear. So this is the Scottish GP Register study, and this is the Sally Ann Cooper in Glasgow, as I mentioned. These are using the DCLD and scales and the multiple physical and mental health comorbidity in adults with IDD. And basically you see the odds ratio of schizophrenia, anxiety, depression, anorexia, and alcohol use I think the Scottish people with intellectual disability can't afford the whiskey, I think. So this is interesting finding, though, with the psychosis, which is also very consistent with the studies by Angela Hasiotis on psychosis with the British studies in England. So, a Scottish registry study, multi-morbidity higher. So they had both physical conditions and mental health conditions. And that was common in all age groups in adults with IDD. And then extent of the morbidities were under-recorded. And the mental and physical health conditions were unrecognized often and under-investigated, under-treated, with ill health presenting late presentation, at more severe stages of disease progression that is less responsive to treatment. That is exactly what we found in Nigeria among children with intellectual disability and autism referred to clinics. They present late, they present with intellectual disability, comorbidity, and they are untreated and under-attended to in the system. They left at home. And if I go to certain regions of even a low and middle income country, not mention any names, we will find the same pattern. This is an important pattern. That's a public health pattern. It's not just specific to intellectual disability, but it's a vulnerable population, okay? And this is across the lifespan. So these are the Scottish Primary Care Registry patients, and then this is the physical health conditions, and this is across time, this is the lifespan, and you'll see the cumulative, the area under the curve, for those of you in statistics, are the cumulative number or proportion of people with 2 or more physical health conditions in men and women. And you can see that this is the no intellectual disability, the light line, and this is the intellectual disability. And it starts early with a higher level, and the others, as they get older, by age 70, they catch up with some of the physical disabilities, I'm sure. And as you get, there's only one dictum in epidemiology. As one of the epidemiologists said, in the final analysis, everyone will be dead. So that's the epidemiological dictum. So, if you live long enough, you will all have either Alzheimer's or you'll be dead. So, all right. So this is the mental health conditions. So you'll see mental health conditions much worse impact in the intellectual disability population across time. And this is true for women as well as men. Okay, these are solid data, okay? So this is people with 2 or more physical conditions and 2 or more mental health conditions. Again, you see the same pattern across, and it actually, there is no, it's a smooth curve, and it's, again, very important increases in relative risk of, among individuals, both men and women with intellectual disabilities. So the Scottish GP Register study, so these individuals also were living sedentary lives. They were less mobile, they were not participating in society, not exercising, mobility problems, had obesity problems, less likely to eat healthy, which is also true for patients with schizophrenia. There are many studies of that schizophrenia patients where actually it's worsened by the metabolic syndrome with this risperidone that they're on, which is also a problem. I'm not saying that we shouldn't prescribe the risperidone, but I'm just saying that it needs to be monitored and they need to be on a healthy diet. And then prescription of multiple drugs to have the knowledge to make healthy choices, which needs guidance because they need coaching, they need careful attendance by others because they don't know. They actually like all sorts of foods that are totally unhealthy, and they will eat that and they will insist, and they might have behavioral issues if they don't provide the foods for them, especially if they gain weight and they get reinforced by food. Sometimes they use food as a reinforcer for people, and that makes it even worse. So all of this is compounded by difficulties accessing the health services, because you can't really get help unless you have these kinds of advice and that they're available. This is German data, mental health needs and availability of mental health care. So 50% of children and adolescents with IDD had higher total problem scores. They had OCD, aggressive behaviors. Parents of children with more severe problems reported more difficulties with the mental health system. So this is actually also true for Netherlands and Germany. They said professionals do not feel responsible or were not sufficiently skilled for the treatment of our family members. And this is in Germany, and this is the same in Holland. My friend Dr. Wieland has done some studies there, and I will show you with borderline intellectual functioning. And 96% of the parents requested specialized mental health services. By the way, in the ACAT study, only 10% of those identified with mental disorders and intellectual disability received specialized services. Okay? So in Turkey, that must be much lower. Okay? So this is the physical and mental health of young people. Now this is the transition period study, which is very important. So the transition, what were the transition periods? Okay, so these are the transition periods. First of all, they looked at the main overall transition period of 13 to 24, okay? But then they divided that up into 19 to 24 and 13 to 18, okay? And so there was a significant disparity in health between young populations with and without IDD. And then the 19 to 25-year-olds with intellectual disability more likely to have mental problems than the 13 to 18-year-old reference group. So the older group had more problems during the transitional ages of intellectual disability. These are all areas that you can study. I mean, these are just, you know, if you want to look at this types of research. So again, autism. This is a very important comorbidity for autism as well as intellectual disability. It's an important predictor of challenging behaviors. When there's an intersection with autism and intellectual disability, there is comorbidity with autism spectrum disorder, there is self-injurious behavior. It's a terrible, terrible outcome. And also this is correlated with language impairment. So if you have a child with severe autism, intellectual disability who's nonverbal, the likelihood of self-injury goes skyrocket. Okay, so this is self-injurious behavior, and the treatment is really behavioral, and this is something that Tohum Vakfı is very interested in, because there is really limited services for these families, and they're really desperate. And because the behavioral interventions, also the functional behavioral analysis, very, very important, very lacking, and we don't really have the resources to implement them. It's not just medications. I gave a talk, I think we have like a few people attending today, but the largest audience I have ever had was when I talked to the American Association of Intellectual and Developmental Disabilities. I think there were like 800 people in the audience, because I was talking about psychopharmacology of self-injurious behavior. And then I said there is no psychopharmacology of self-injurious behavior, and there are all these things that have been tried. And the most controlled studies on naltrexone, for example, is the one that has been used in placebo-controlled randomized trials, and with mixed results, actually. So severe and profound IDD, so let's get to this profound IDD, had more physical disabilities. So you shouldn't be surprised for that, because they have more congenital, rare, genetic, chromosomal syndromes, as well as seizure disorders. And then lower scores across the DBC scales and DBC detection bias in severe and profound, as I mentioned before. So going back to the national comorbidity surveys, nonverbal score from again, as I mentioned, the Kaufman Brief Intelligence was used, and they looked at this might be interested to those of you interested in deprivation and threats, and so they looked at threat types which were the more likelihood of, for example, physical abuse or witnessing domestic violence, and also the deprivation, which has to do with poverty and low parental education. And so this is the study looking at that, and you can look at these threat types. For example, sexual abuse was not as high, and I think it might be underreported. Physical abuse was higher. Domestic violence, these are the plots with the squares. These are the deprivation scores. And then you have the one with the triangles, which include the financial insecurity, food insecurity, neglect, and so on, and any kind of threat. So you'll see all of them are elevated. So this is borderline intellectual disability, and we have a president who's very interested in borders, so we can talk about that. So this is the 13.5% that I mentioned, and this is where we are within the first and second standard deviation. This is the group that's closest to the mild intellectual disability. In fact, there's very limited difference between mild intellectual disability and borderline intellectual disability. And any study that includes intellectual disability should use borderline intellectual disability as use measures that we'll get into, like the Kaufman study, Kaufman measures in the Platt study in the National Comorbidity Savers use 76. I would go up to 80 and then sort of put some stratification to compare, and you will find actually that there might not be that much difference between the two. So this is the only diagnosis, including intellectual disability, that's defined by a bell-shaped curve. Okay, there's no diagnosis in psychiatry that's defined by a bell-shaped curve. Okay, and this is the legacy of eugenics. Okay, all right. So this is the gray area. Higher rates of incarceration. You'll see many of these people in jail, in juvenile detention centers. They are more likely to have mental problems. They are more likely to have depression, psychosis, substance abuse, and because they have more access to the population, they're more likely to be gullible, more likely to be vulnerable, more likely to be abused. Okay, and so increased suicide attempts and self-harm. I don't know if you know treatment of individuals with Williams syndrome. You know, I don't know if you've seen adults with Williams syndrome. They're extremely friendly. And when they go to men, they're very interested, especially if Williams syndrome women, and they get abused very well because they have very poor social judgment about that. They're extremely friendly. They go to see you, and then they come and sit on your lap, and then they look at you, and then of course if you have some pathological figure, they will be very badly abused. And this actually, I was at a meeting in England where I saw that. I went to I think it was the St. Mary's National Health Service. I was visiting one of my colleagues, and I went to this meeting with the consultant and the registrar and the social worker and this patient, and this is exactly what they were talking about. She was living in some kind of a housing, and this guy was looking at her door and coming and having, sexual relations with her and abusing her constantly. He was an older man. So this is what I'm talking about. And of course, adverse, and also just to say that when they have PTSD or when they have traumatic grief, or traumatic loss, it's underestimated. You don't understand it. They might have behavioral problems as a manifestation of traumatic grief or PTSD. So, adverse childhood experiences, those of you, again, interested in research on adversity, this is a very important field. Children with IDD are at higher risk of exposure to ACEs. 57% of the general population experience one or more ACE. This was a study from Lancet. And children with IDD are 3 to 7 times more likely to experience neglect, physical, emotional, and sexual abuse. And those who experience an ACE are 4 times more likely to have adult mental disorders, depression, and anxiety. You know, in epidemiology, we have absolute risk and we have relative risk. And the relative risk is actually always worse than the absolute risk. So, so in terms of using, so these are relative risks. Okay, so this is proportional frequency distribution of exposure to ACEs, and you can see in the, this is an analysis from the British studies, 1970 British birth cohort, and you see much higher evidence for ACEs and association between exposure to ACEs and material and or social deprivation. And you can see that this is, again, exposure is related to prevalence of possible mental health problems. These were not exact mental health, mental disorders, or mental distress that was used in this British cohort study. So the blind spots, this is from Dr. Wieland, increased sixfold in 1998. So these are the care needs of this population. Why is it increased? Why is the borderline intellectual disability population needs increasing? Well, I think you should know that, because those of you who use Instagram and Twitter and sign into Facebook and forget your password every time, and then you have to re-sign in and have to store it somewhere, you don't know where you did, and I'm talking about myself, of course, but and Wachtet. The issue is that so these individuals, then you get instructions to follow A, B, C, D, E, F, G, and you can't, and then you have artificial intelligence, and you have drones flying around. We have Amazon that's going to deliver groceries by using drones in front of our houses soon. I can order food from a grocery store online. I don't need to go to the grocery store, and it's unbelievable. So if you don't know how to use a computer, you can't do any of that stuff. And also you have adversities, you might not be able to afford to have a computer. So what did the Dutch say? Well, 30% of the patients had an IQ of less than 35 in these centers. These were actually mental health care centers, community centers in Holland. Where Jenny Lien was working at the time as part of her PhD dissertation. 34% of the organizations had IQ of 85, borderline intellectual. 57% of the organizations lacked knowledge and expertise to treat patients with an IQ of less than 85. That's exactly the same complaint as they had in Germany, in Holland. And then the PTSD in persons with borderline, and higher rate of PTSD, and they had actually less mood and psychotic, but that was a bias because they were referring patients to other centers. So this is the British Psychiatric Morbidity Surveys that looks at studies, and that's very relevant in terms of adult psychotic disorder findings in Britain. These are nationally representative National Center for Social Research surveys. And actually these databases are available on the internet. You can download them, you can request the data, and you can analyze this data and publish papers. So it's incredible. So the British Morbidity Survey, psychosis results significantly associated with psychosis and auditory hallucinations and these borderline intellectual functioning. Presence of auditory hallucinations was not due to other diagnoses like borderline personality disorder, and there was a link between BIF and psychosis mediated by depression but not anxiety. And important recommendation, targeting common mental disorders and building resilience. The reason why I think that anxiety might not have been as important might be that anxiety is more common and you need a greater power to detect differences and this kind of thing. There are a lot of statistical issues here, but you see depression as being a very important mediator. So this is the British cohort study. This is an unbelievable study. These are people who were born on the week of April 5 to 11 in 1970. In England, and now they're like in their almost 50 years old, and they have been followed at these ages, and this BIF was identified using cognitive testing, which was used at age 5,
And these were, again, look at that, 13.6%. Well, there's statistical bell-shaped curve. And this is the foreigners with ID, borderline intellectual functioning, and without. So they use the statistical cookie cutter over there. So higher risk of poor health and health behaviors, and I'm going to get to that, and then higher risk of exposure to well-established social determinants of poor health. So health. So mortality, higher. Okay, so I'm just going to zip through these. If alive at age 5, children would be 4 times more likely to die by age 10. These are children, okay? So these are general health, fair or poor. These are maternal reports at age 16, then self-report, following up as they get older. And the question formats vary, and then this is what they report. This is obesity, which is 16 to 20% greater risk among adults with BIF. And then mental health, as I mentioned before, obviously. And they use this malaise questionnaire, which I think doesn't exactly correspond with mental health, but it correlates with it. And this is the low sense of control over life, what they report. And then health behaviors, and these are smoking. You have much higher elevated rate of smoking. And these are like had tried a cigarette, smokes 5 times a week, smokes 20 cigarettes a day. And then exercising, you'll see exercise last Saturday, exercise how many days a week, again, differences. Health determinants, association between this, the 13.5% and low socioeconomic position. By the way, as you go down the IQ score to very profound and severe, because it's more sporadic and genetic conditions, the SEP, the social economic position, is not as relevant. The social economic position is always relevant for mild intellectual disability and also for borderline intellectual disability, which is very similar to mild intellectual disability. These are pearls, by the way. I mean, this is just, you have to know that, because it's very important that you understand that anything that is more mild is paradoxical, but it's more mild that actually associated with more socioeconomic position, because there is something about poverty that is also causing that, and the conditions in which people live, and the adversity in which they're exposed, as I mentioned to you with the ACEs that we talked about. So, and this is self-assessed financial status, difficult or very difficult. And then self-assessed financial status, living comfortably, again, problematic. And then employment status, and a stronger association with unemployment, living in rented accommodation, higher rate of living in rented accommodation, living with partner. And so workplace adaptation, successful adaptation to independent living and workplace adjustment is strongly influenced by the severity of the mental disorder. In fact, the severity of the mental disorder is probably one of the most important predictors in this population. But not only that, it's also the most important predictor of parental mental health and familial parental health. And it's not necessarily genetic. It is to do with the stress on the family as well. So these are just to say that we have a very important principle of social inclusion in the United States, which is part of the policies that were passed. We actually work in Institute for Community Inclusion, which is part of Children's Hospital, which is funded by the University Center for Excellence in Developmental Disabilities. And so these are healthy development promoted by building strengths, protection, and then individuals participate as active decision makers as much as possible. An ecological approach recognizes development is influenced by multiple systems and contexts, and then all individuals find a sense of meaning and quality of life in their lives. It's very important, and strengths-based programs and supports that help individuals overcome adversity. And these are positive development, promoting bonding, very important for attachment failures and this depression vulnerabilities and grief vulnerabilities that I mentioned, because there are very few people in their lives. So when they lose a loved one and the support, their reaction is overwhelming. And those building strengths, as I mentioned, fostering spirituality, that's actually not a bad idea, and developing self-efficacy, hope is important, and promoting positive behavior and opportunities for pro-social involvement and social engagement with others, which is very important for this. As you know, the social relatedness got worse over time, so that's very important. So I have like a few summary slides, and I'm going to be ending, and then we can have some time for discussion. What are the key points? So co-occurring mental disorders in persons with intellectual disabilities are common. Okay, that's the first point. They're common, and they're persistent, and they're substantive. So those are the 3 points that I want to make very briefly. If I were to use one slide for this presentation, that's what I would use. And then higher rate of exposure to well-established social determinants, as I proved to you that there is a very high rate of adversity to social determinants, and both traumatic social determinants as well as determinants of deprivation. Okay? Adaptation to education, independent living and workplace adjustment is strongly influenced by the severity of the mental disorders, as I mentioned again. And then mental well-being of parents and families of children with IDD is influenced more by the severity of the child's co-occurring mental disorders than the intellectual disability severity itself. This is probably the most important point for psychiatrists, because if you have a child with mental disorder in your family, your mental health is at risk. Okay? So the public health and clinical implications of intervention. So intellectual disability service design. This is an important point. Need to be with the knowledge that a very high proportion of persons with IDD will have substantial and persistent co-occurring mental disorders. So if I was the Minister of Health and I'm designing mental health services and I'm sitting in the room around an elliptical table, I would ask, so what are we doing for kids with intellectual disabilities? Not because I work in the field, but I would say because they share a higher burden. And that is what we call in ethics distributive justice theory. So those who have greater burden need more help. Those who have less burden need less help. And it's also a needs-based assessment. So early intervention should aim at reducing the prevalence. We know that early intervention works, irrespective of the specificity, although we are trying to improve the specificity. As you know, there were presentations yesterday in our session. So there is a program called RE-AIM, which is the Rich Effectiveness Adoption Implementation and Maintenance Framework for the National Core Indicators. I mentioned to you the National Core Indicators in the United States, and this is actually something that they've been thinking to monitor individual, family, and organizational characteristics. This is a very important program, those of you interested to find out, as a model, because what they do is they're monitoring individual characteristics, family characteristics, and organizational delivery characteristics. For example, they're measuring things like what is the turnover rate in this community mental health center for community mental health workers. How long does a community mental health worker work there on average? And they'll find 3 months. Or you have a school for specialized education services, and they find out that in this school a teacher worked on average 5 years. This is unbelievable. And because usually young teachers, they get married, they have children, and they move on. And the turnover rate is important. But if you have a school like that, I would say that's a good thing. So if it's a very isolated school somewhere and there's no interaction with the rest of the community, and these people just hang in there and they're abusing the kids and nothing is happening, that's another thing. So you need to monitor all these other family indicators, individual indicators, and so on. So this is a very important, you should see the number of indexes that they have in measuring these quality measures. And I know those of you who worked in England also, you know that National Health Service has these kind of quality measures. Actually, consultants get bonuses based on how well they do, and so on. And they put it on their internet web pages, and also they put it underneath their email saying, we won this award for our National Health Center. And I think you see that in the PAC group, actually, but interesting. So leverage supports to enhance skills in training parents and caregivers, as well as providing special relevance to the burden of care. So it's very important to always leverage supports. What I mean by that is that if you have limited resources, you need to share resources. You need to use the resources efficiently. Okay? and that saves money. That means cooperation between systems, welfare system, mental health, healthcare system, education system. They need to cooperate. They can't have silo systems, each spending the same amount of money. Okay, so thank you. Just to say, as I always show Charles Darwin, so basically he visited Australia on the back from the voyage of the Beagle. He came to Australia. He was so impressed by the Englishmen establishing this wonderful city of Sydney, in the Sydney Harbour and the Sydney Cove, and he saw these beautiful brick buildings. Some of them were prisons for the prisoners, and some of them were his classmates from Cambridge and Edinburgh that he had been, where he was studying, and about the same generation who moved to Australia. So he was very proud, but then he said, I can't live in these shores because it's sort of, I would not be able to afford this idea of living in such an isolated place. So I'm so delighted to leave Australia, he said at the end. But what is very interesting is that, and I read this, Charles Darwin never saw a kangaroo in Australia, but he was the first scientist to set eyes on a platypus, which is very deceptive. So, and I think some of the data here would have been, if you didn't attend this course, maybe it would have been deceptive. I don't know.